والصلاة والسلام على خاتم النبيين وأشرف المرسلين سيدنا محمد الهادي الأمين وبعد. أنا هتكلم عن استكمالا just to continue what I was talking about in the morning regarding the general outlines or the general principles of chronic disease management in clinical practice, and I have spoken about many issues, and I have focused on the importance of addressing and recognizing the pathobiology or the pathophysiology of the disease in order that your therapeutic decision or your therapeutic approach as a clinician should focus on it in order to be successful in your patient management. You should, I am speaking to the clinicians, to the doctors, to the physicians at all levels, juniors and seniors, that they should address, he or she should address the pathophysiology of the disease. That's why all physicians should read and study very well the pathobiology of disease. The pathobiology of disease. And there is a textbook, a big textbook and a big reference, or we can say many references by different editors. You can get them from the Amazon or from regarding the pathobiology of disease. The address of the reference or the textbook is Pathobiology of Medical Diseases. That is medical conditions. Every disease has pathobiology, starting from the etiology, the cause of the disease, or what you call the etiology of the disease, and then the pathogenesis, and this is the etiology and the pathogenesis, we call it the etiopathogenesis of the disease. And there is what we call natural history of the disease, and I'm here speaking about especially about the chronic diseases. There's a natural history of the disease, although it is to some extent applicable also to acute disorders or acute medical conditions, even emergency medical conditions, as I have given examples of these conditions in the morning before talking about the chronic diseases. But now I'm especially focusing on the chronic disease. Every chronic disease has a natural history and has a biological course. The natural history, it means that it passes from stage to stage, from a phase to another phase with time. This is in any chronic disease, because chronic diseases, as I mentioned before, is either chronic diseases, progressive diseases, or they are intermittent diseases or have intermittent course with remissions and exacerbations. While acute medical conditions are usually regressive diseases, not progressive diseases. They are progressive, they are regressive, the acute medical conditions, like pneumonias, like acute respiratory infections, like acute UT infections, like gastroenteritis, like acute infectious diarrhea, like acute hepatitis, viral hepatitis or alcoholic hepatitis, like acute pyelonephritis, even the meningitis and the endocarditis, which are serious systemic infections, also they are regressive at the end. If they are given the proper treatment in the proper time, and they are put under control, and they are managed properly from the beginning, they will be regressive, and they will finish the short natural course of the disease, and the condition will be cured. This is in will be treated or cured. This is in acute conditions. But in the chronic conditions, the course is usually different. The natural history is different. The biological course of the disease is different in chronic diseases, because they are either progressive, again, I repeat again, either progressive, not regressive, progressive, or intermittent, with remissions and exacerbations, or sometimes got remissions and relapses. So the natural history of the chronic medical disease or chronic medical conditions or even syndromes, they are, which are either progressive or intermittent, again I repeat, they have a natural history and they pass from stage to stage. So they are progressive. And also they are not only progressive, they are heterogeneous in presentation, in clinical presentation from patient to patient, depending on the severity of the disease and the duration of the disease. But to repeat again, the chronic medical conditions or chronic diseases, they have a natural history, which every physician should understand, the natural history of that disease. For example, natural history of diabetes, type 2 diabetes. What's the natural history of type 2 diabetes? As a heterogeneous progressive disease. What's the natural history of systemic arterial hypertension? What's the natural history of pulmonary hypertension, which is another hypertension? What's the natural history of portal hypertension, which is another hypertension? Because not every hypertension inside the human body is systemic arterial, but the most common type of hypertension is the arterial hypertension, which many people in the society and in the community and in the world are suffering from. But there are other types of hypertensions in clinical medicines inside the human body. I have spoken about that in a different clinical lecture before. The types of hypertension inside the human body, including the arterial hypertension, the systemic hypertension, the pulmonary hypertension, the portal hypertension, the intracranial hypertension, the intraocular hypertension. These are the most common types of hypertension inside the human body. But when we say hypertension, just hypertension, we mean the arterial hypertension, which are either primary hypertension or secondary arterial hypertension, affecting the systemic circulation, not affecting the pulmonary. The pulmonary, we call it pulmonary hypertension. If affecting the portal circulation, it's portal hypertension, which is a very common complication of liver cirrhosis. Intracranial hypertension, if there is space-occupying lesion inside the skull, intracranial, like tumors, like cysts, like foreign bodies, like any space-occupying lesion inside this closed compartment, which is the skull, it will produce intracranial hypertension. Of course, also another category, fourth category, is the pulmonary hypertension with all its types. The primary pulmonary hypertension, the secondary pulmonary hypertension, the portopulmonary hypertension, the obliterative pulmonary hypertension, the obstructive pulmonary hypertension, etc. All types of pulmonary hypertension. I'll come back again to hypertension, to diabetes, or to they have a natural history in every type of these types of this clinical syndrome. The hypertension, for example, is a systemic hypertension, or in the diabetic syndrome, whether the type 2 diabetes, which affects mostly adults, and type 1 diabetes, which affects mostly children. Of course, we have exceptions, and we have other types of diabetes, like secondary diabetes, due to endocrine causes, due to pancreatic causes, due to metabolic conditions, the all causes of secondary diabetes, including the endocrine, the metabolic, the pancreatic causes, etc., which cause secondary. And this secondary diabetes is treatable, because once we treat the cause, the diabetes will disappear, will be treated. Also, the gestational diabetes, which is diabetes happening or occurring during pregnancy in ladies, we call it gestational diabetes. Once the gestation, that is the pregnancy, finished and postpartum, the diabetes disappear. Although many of such cases, they might get future established diabetes. That's why we have to follow them up in order to detect any established diabetes later on. They are susceptible to get full-blown picture of diabetes later on. Those who have suffered from diabetes during gestation or during pregnancy, we call gestational diabetes. In addition to the other types of diabetic syndrome, like diabetes due to genetic factors, the monogenetic syndromes, like the MODY syndromes, the maturity onset diabetes of youth, with all its categories, 6-7 types of MODY syndrome, the type 1 diabetes in adults, the type 2 diabetes in children, which is pediatric type 2, which is especially common in obese children, And it's not related to insulin deficiency like in type 1. It is related to insulin resistance, similar to the type 2 diabetes in adults. So there are many categories of diabetes. You as a physician should understand the natural history of the disease, and you should recognize the biological course of the disease and at which stage of the disease is your patient. Because as I mentioned, meaning that there is a natural history and there is a biological course means that and being progressive disease, this means that it will pass from stage to stage. And at every stage, there is a different policy in disease approach. That is, in therapeutic approach, the management differs from stage to stage. That's why you have to address in every individual case of every category of chronic disease, as exemplified, for example, by diabetes and, as I mentioned, and by hypertension. You have to address at which stage of the disease is your patient. Which stage of the disease? Is it an early diabetes, early diabetic type 2, or is it an advanced case of type 2 diabetes? You have to address many features of the clinical phenotype, what we call, of course, in addition to recognizing the genotype, if the diabetic syndrome is related to genetic disorders like those cases with Modi syndrome, or many cases of the type 1 diabetes, pediatric type 1 diabetes, or the other polygenic diabetic syndromes. You have to recognize the genotype in every individual case, in order to apply the concept of what we call the precision medicine in diabetes, for example. And you have to, in addition to that, you have to recognize or address the severity of the disease at each stage of the disease, of course, or at each phase, whether in early stages or in later stages in advanced disease. You have to recognize the severity of the condition. Is it a severe diabetes that is very high hyperglycemia, or it is mild hyperglycemia or moderate? The severity, the duration is very important. For how long does this patient have the diabetes or the diabetic syndrome? Duration. The age of the patient is very important, because this will affect your therapeutic decision. Is it diabetes in child? Is it diabetes in adult? It will affect your diagnostic decision and your therapeutic decision. So because the issue is different between pediatric and geriatric, for example, the extremes of age or the extremes of life, or in the middle age. Because not every middle-aged diabetes is type 2. Sometimes it is type 1 in adults, or the LADA syndrome. Sometimes it is Modi syndrome, maturity onset diabetes of the young. So you have to understand this, the duration of diabetes, the severity of diabetes. You have also to recognize and address any complications present in every individual case. Does the patient present to you with complications or not? And which complications and which organs are affected? And the presence or absence of end organ damage. For example, in hypertension, hypertensive nephropathy, or hypertensive cardiopathy, or hypertensive cerebrovascular disease. These are target organ damage in patients with systemic arterial hypertension. And this can be applied to any other medical conditions, chronic medical conditions, like chronic obstructive pulmonary disease in the chest, or bronchial asthma, or epilepsy in the nervous system, or chronic headaches like chronic migraine, or vascular headaches, including migraine, cluster headache, etc. You have to recognize these issues in order to fully understand the clinical phenotype of your case. In addition to, as I mentioned, the understanding the genotype, if your case has a genetic basis or genetic predisposition in the etiology of the disease. In order to apply the concept of precision medicine, you have to understand the genome of the patient sometimes, because genetic factors is different from acquired or environmental factors. You have to recognize such conditions. Is it a problem in the lifestyle of the patients? You have to correct it also. This is very important in order to guideline the patient regarding a healthy lifestyle, healthy eating behavior, movement that is regular exercises, and to have a good sleep, and to avoid stress, and to avoid bad habits like alcohol and like smoking and these things which might endanger the clinical course of the disease. So you have to address all of these factors in the clinical phenotype of your patient. End organ damage, complications. That's why in the follow-up in chronic disease management, you have to have regular checkup with the physician. In order to check all of these things, the physician or the clinician will check all of these things which I mentioned. And he will outline and recognize and address all of these features of the your phenotype, and so will design and will tailor the best therapeutic approach for you. So here the regular checkups and the regular visits to the doctor, to the clinic, is very important, whether doctor's clinic or OPD clinic in a hospital, in order to check your disease regularly and at the same time to check your medications. Do you need change of any medications or not? Do you need to have more medications or to have less medications, to provide you with an extra medicine, or to remove one of your medicines, or to redesign your therapeutic approach? Instead of using 3 medicines, he will give you 2 medicines in 1 tablet or in 2 tablets. So revision of your disease and revision of your drugs which are given to you before is very important part of the regular checkup in the clinic. That's why the regular visits, and the doctor will tell you, come for follow-up, which is different, of course, from patient to patient, as I mentioned in my lecture before, in my live broadcast before. It differs from case to case. Is it a monthly visit, or a 3 monthly visit, or bi-monthly visits, or more frequent than that in the month, every week, for example, in severe uncontrolled diseases, especially diseases which are recently diagnosed, and or patients who are newly evaluated by new doctors. He must have more frequent checkups. Or if the disease is put under control, it will be less frequent checkup, but the patient should have a checkup again. Even if less frequent, he should. When the doctor tells you that you must come after 1 month, you must come after 1 month, or after 2 months of the, to revise the disease and to revise the medications of given before. Maybe he will change the drug plan for you, or the medications plan for you. It will be more medicines, less medicines, depending on the your status and whether you are controlled or not, and whether there are any new complications or not. And may also the doctor will change to you the medications, as I mentioned, or change the doses of the medications. This is all very important in disease management. And this is the purpose of regular clinic checkups or regular clinic follow-ups if you have a chronic medical disease, for the disease and for the drugs. That's why when I tell you as a clinician to please come back again after 1 month or after 2 months, you should respect that. And you should come back because the doctor has a purpose. Revision of the disease and revision of the medications. Whether revising the schedule of the medications, or increasing doses or decreasing doses, or increasing medications or decreasing medications, or addition of medications, or any other new therapeutic decision or therapeutic plan, this should be done by the clinician on regular checkups. That's why regular checkups is very important part of chronic disease management outline. In order that your disease will be under control, you are under control, you are not at risk of any future complications or life-threatening events like diabetic ketosis and diabetic syndrome, or hyperosmolar coma, or hypoglycemia, or which is more dangerous than the hyperglycemia. To avoid all of these things, you should have follow-up to revise the disease and to revise the medications and avoid any complications and provide you with better quality of life and better functional status of you. That's of the case. Thank you so much, Professor Dr. Tarek Ali.